The Academy has honored us over the last 6-7 years to allow us to present this quite erratic for standard cornea knowledge treatment, and I'm happy to report to you some long-term results establishing the safety and efficacy of this. We have treated, starting in 2004, over 1,500 patients with keratoconus, and this technique involves combining a topography-guided normalization of the surface. It really doesn't make justice to use the word PRK for this treatment, because this is not a refractive treatment, and I'll elaborate about this a little bit later. And following that, high-fluence collagen cross-linking, 10 milliwatts per square centimeter for 10 minutes. Patients had variable follow-ups, some of them over 5 years, and were evaluated for standard refractive and visual rehabilitation outcomes. We have reported previously our technique in multiple papers and book chapters, and in essence, the treatment involves these 4 steps. First, a PTK, 50 micron PTK at 6.5 millimeter diameter, and the purpose of this is to use the epithelium as a masking agent, taking into consideration that the cornea epithelium in keratoconic eyes is highly irregular. Second, we use a topography-guided treatment to try and normalize the extreme irregularity of the cornea. It is obvious that setting a goal of not exceeding 50 microns on the peak of the cone, this treatment as a refractive treatment only can correct 1 to 2 diopters of refractive error. Following that, application of mitomycin C, and then high-fluence collagen cross-linking. We had proposed this entity several years ago, and this is our routine. How does it work? We import into our laser 4 different types of topography analyses, and I have to disclose that this is not FDA approved in the United States, any of these, although the devices are. So out of these, you can compile this treatment that you see here. This is a very complex treatment, and I will ask you to concentrate on this part of the treatment here, which resembles a small ectopic myopic treatment, and it is directed over the peak of the cone. But what's interesting in this proprietary software by Wavelight, and I do consult for Wavelight, is this part hyperopic treatment, which will aim into making the area around the cone become steeper and thus normalize the surface without removing much tissue. In our calculation, this removes 1/3 of the tissue of what a wavefront-guided treatment would do, if a wavefront-guided treatment was possible, because most of these eyes do not measure on wavefront-guided. So on our platform in Europe, we are able to import seamlessly these measurements from the Oculizer 2, which is built on the Pentacam HR, and make sure that the axes of the astigmatism are similar, and compare them for reproducibility. All the pachymetry data automatically come onto the laser, and this is what the treatment has been catered to. We have to, unfortunately, decrease the optical zone to 5.5 millimeters in lieu of saving tissue. So these are very small optical zone treatments, and not go over 50 microns at the thinnest part of the cornea. And I showed you the PTK before. So this is the procedure, just a few seconds. This is the PTK part. You can see that it has gone through Bowman's in the periphery and over the cone, and this is the topo-guided PRK normalization. And then mitomycin, and we can have sound off, followed by riboflavin drops, 5-phosphate, not in dextran, and no soaking, immediately onto cross-linking. This is the Avidro device, and I do consult for Avidro as well, for 10 minutes. These eyes do have a rough time healing. They are a rough PRK, so to speak, if I can use that term, so they take anywhere from 3 to 6 days to re-epithelialize. We have shown in the past that doing both procedures is advantageous, and going into some clinical examples, this would be a case that for sure 10 years ago, in my New York City office, I would recommend a cornea transplant if RGP was not possible to be fitted. And we're able to normalize this cornea, somehow reduce the index of height decentration that I do propose as the core index in evaluating keratoconic eyes and their visual function, and not visual acuity and refraction. This is a case that represents more than the ones that we see in our practice, and we see about 50 young keratoconic males a week. The male to female ratio in our practice is 10 to 1. So you can see here severe keratoconus, and again the IHD improves from 0.08 to 0.01. This is a dramatic treatment, although refractive-wise, this would be a terrible treatment as a LASIK outcome. As you can see, high refractive error post-op. This is one of the star patients that we had encountered. This was a helicopter pilot for the New York Fire Department that had LASIK, and you can see here developed ectasia. He came out to Europe. We did the treatment. This is him several years later. I'd like to draw your attention on how the difference before and after mimics the treatment plan, showing the high specificity of this treatment to deliver what we aim for. This patient is 2010 and is currently jumped into active duty with the Air Force. Another similar example, and here we're inducing myopia. So the patient starting with a spherical equivalent of about -0.5 ends up with a spherical equivalent of a -1. So again, this is not a refractive procedure. This is a procedure to normalize the cornea and improve best spectacle corrected visual acuity, which you can see here. All eyes had improvement from 1 to 4 lines in best spectacle corrected visual acuity, although the refractive error was not highly predictable. And here are the keratometries, another word of caution from our follow-up, that they tend to be reduced for about a diopter to 2 over the long time period, which makes the point to undertreat myopia when you're manipulating the refraction of these patients, so not to overtreat them. This is some of the epithelial healing issues. We've employed amniotic membrane, autologous serum, and careful follow-up not to have these epithelial difficulties turn into scars. So we're very pleased with the dramatic improvement in the IHD and the best spectacle corrected visual acuity, as I mentioned before. And in conclusion, this is not a refractive treatment, it's rather therapeutic. Although the sphere refractive result is non-predictable, the improvement in best spectacle corrected is extremely predictable. No other treatment has been able to match these results for ours. And I thank you very much for your attention.
Okay. Any questions from the audience? Could you clarify the riboflavin protocol for the audience if they're not familiar with the Athens Protocol? You mentioned you put the riboflavin drops on immediately after the PRK, the modified PRK. How many drops and how long do you spend on that step?
The original Dresden protocol entailed removing the epithelium and soaking the cornea for a half hour with a dextran diluted riboflavin solution. We use a sodium 5-phosphate riboflavin solution, same concentration, 0.1%, which is a much thinner solution. And since we've broken Bowman's and stroma in these cases, it's bioavailability when the cornea is immediate. So as soon as you start putting drops on the cornea, within a minute, so to speak, it can reach halfway into the cornea. And I've, for years, advocated that it is a disadvantage to soak the whole cornea with riboflavin because this potentially increases the UV light toxicity to the endothelium. It is UV light and riboflavin at the endothelial level that will cause toxicity, not UV light alone. So that's why we've swayed away from the soaking time.
Do you have a sense for the incremental benefit of combining the PRK and the cross-linking? I don't believe there's a controlled study or a match study where you have patients who just get cross-linking and patients who have the combined approach. But if I can just ask for your feel on that.
One of the difficulties with this is an excellent question. We have 2 severe problems with cross-linking. We do not have a measurement, an outcome measure of how much cross-linking there is achieved, so we're just observing these eyes clinically, and if they do not progress, then we say we achieved cross-linking. The other problem is that it's unfortunate that it has not been available in the U.S. and there is no scientific backbone of this technique as with other procedures. And currently there's about 100 protocols being performed globally, and unfortunately all of them are case series. So there's no big multi-center controlled study to compare to.
Could I ask a question? So this is, I mean, great results. I mean, it looks wonderful. Did you ever try, I know the advantages of combining the two, time-wise and ability to get this riboflavin in, but since cross-linking does change the surface of the eye, would it be advantageous to do the cross-linking first, wait, and then do this procedure after, and maybe get better refractive results?
It's a very good point, and we've actually published in 2009 a series of 200 patients that had cross-linking first And then they had a topography-guided manipulation 6 months to 2 years later versus the combination technique. And the advantage of the combination technique is that it appears to be synergistic to reducing keratometry and improving best spectral corrected visual acuity. You could theoretically do this, and sometimes with conservative patients, they prefer to do the cross-linking alone. The disadvantage of that is when you go back to do the laser treatment, you're removing some of the best cross-link tissue, because this happens more superficially and less below. Plus, in our experience, there is no nomogram in lasering cross-link tissue. It is very easy to overtreat. So if one was trying this, I would strongly advise to use a nomogram of 50% of the planned treatment. So,
Dr. Bourne?
Have you compared, or do you have evidence of what effect you have from the mitomycin, because the cross-linking kills the keratocytes down 300 microns?
It's a very good point, and theoretically, since you are manipulating keratocytes with the cross-linking process, you would think that you would not want to use mitomycin, and colleagues from Central Europe do not. We tend to get some PRK-related haze and scarring if we do not use mitomycin in our cases in Southern Europe.
My question is along the same line. It's been shown, Jamie Jesser has done a lot of confocal microscopy studies showing the effect of mitomycin C on the keratocytes, and it pretty much wipes them out. And you're using them for 30 seconds, I saw. With the additional loss from the cross-linking, is there concern, or how many of those non-healing corneal ulcers went on to have, really long-term bad consequences and infectious keratitis and so on?
We have not had delayed epithelial healing turn into infectious keratitis, but in eyes where this was not monitored closely, we've had a few cases where it ended up in a subepithelial scar. And it is a good point. We are not able to titrate it, whether it's the mitomycin toxicity to limbal stem cells or the UV exposure to limbal stem cells or the apoptotic debris from the keratocytes killed with the cross-linking process that make the epithelium have this delayed healing.
Thank you, Dr. Campbell.
Thank you very much.